Hello and welcome to our continuing series in physiological psychology. We're going to pick up on our third part on sexual behavior and focus in this particular lecture on reproductive hormones and cognition. There's a great deal of work being done in this area, some of which I have been privileged to be involved with. And I want to approach this topic from the start to talk about that there are gender differences in cognition, or sex differences in cognition, depending on which way you look at it. I tend to talk about them as gender differences. And when we talk about a gender difference in a cognitive process, we're always talking about in general. So if we look at broad swaths of the population, we're talking about a mean difference. That doesn't mean that any one person is going to be worse at a task because they're male or female, or better at a task because they're male or female. It simply means that overall we see this pattern of differences across males and females. In general, we see that women tend to have better episodic memory and better memory for things like object location. Women tend to be better at verbal tasks. Girls learn to read and write younger. Excuse me. And show higher performance in a wide variety of verbal tasks. Men in general tend to show a higher performance in visual spatial tasks, things like mental rotation, navigating based on cardinal directions, these sorts of tasks. So we're going to take a look at how some of these tasks may be related to reproductive hormones. So the question we often struggle with when we talk about gender differences in cognition is, what is the etiology of these differences? Is it biological? Is it learned? Is it due to structural brain differences, so organizing effects of sex hormones, or is it due to activating effects of circulating hormones? Or are there differences in the experiences of males and females which end up causing some sort of learned difference in these patterns? These are all ongoing questions about these issues, and I want to focus on what we may know about the role of reproductive hormones in these issues. So let's start by looking at body composition. Excuse me. There's a pretty significant gender difference here in terms of the composition of males and females of our bodies. In males, we see body fat is very differently distributed, and we have different types of fat. So in males and females, we have different types of fat distribution and different kinds of fat. Women tend to have fat in their breast tissues and their hips, whereas males carry almost all of their fat as what we call adipose body fat, or that is abdominal body fat. And body fat in these two groups function very differently. So in males, higher body fat is often associated with lower levels of testosterone and higher levels of circulating estrogens, which is why we see in males who have a great deal of body fat, we often can see what's called gynecomastia, which is development of breast tissue, and that's owing to these higher estrogen levels and lower testosterone levels. In females, higher body fat results in higher testosterone levels, and in fact, oftentimes you get what's called hirsutism based on high body fat levels, which include things like facial hair. What's important about this is these can potentially relate to cognition. So in some unpublished research I conducted with Hirshman, we looked at how body fat was associated with cognitive functioning in males and females. And this first graph shows simply correlational coefficients for females in blue and males in green between body fat and mental rotation, which is a visual spatial task, and recognition memory, which is of course an episodic memory task. And what you can see is that for females, the higher body fat they had, the better they were at mental rotation tasks. For males, the higher their body fat was, the worse they were at mental rotation. So low body fat males were performing better, whereas high body fat females were performing better in mental rotation. For recognition memory, we only see an association in females, and that is higher levels of body fat were associated with reductions in recognition memory performance. If we throw in this data into some regression analyses, which include body fat, blood pressure, and heart rate as predictors, what we end up with is seeing that body fat really is the primary predictor. Except for in males, we also see that blood pressure seems to be associated with mental rotation performance. But what you can see is positive associations with body fat and mental rotation in females. That is, higher body fat females were better at mental rotation, whereas high body fat males were worse at mental rotation. Similarly, high body fat females were worse at recognition memory performance. So the open question that we did not resolve in this particular paper is this related to hormone levels? And that's the hypothesis that we came up with, is that because high body fat is associated with increased testosterone in women, that's improving mental rotation performance, high body fat reducing testosterone, reducing mental rotation performance in males, and high body fat potentially decreasing estrogen in females, but then we would probably have expected, if this was estrogen modulated, that perhaps the high body fat males would be better at recognition memory performance, but we didn't see that. So it's also possible that those high testosterone levels were associated with recognition memory performance. There's something certainly different about what's happening in females in this particular data. So if we take a second look at this mental rotation performance data, because again this is a test that tends to load heavily onto gender differences, what we can see is that for the half of our data that were considered high in body fat, we see no difference between males and females. Whereas our lower body fat group, we see a significant difference between males and females. And one of the things this argues for is one of the reasons why we may sometimes see gender differences in cognition and sometimes not is because it may have to do with the overall fitness of the population that we're looking at. So if we're in an area, say the Deep South, at a university where people tend to have higher body fat levels versus compared to, say, also in the Deep South, someplace like Clemson or Georgetown, where I'm at now, where the student body tends to be more fit, you might end up with a very different pattern in data. And so this is one of these areas where there's more to gender differences than just males being male and female. There's certainly stuff lying beneath the data that we often need to look at. Excuse me. So the other area we can look at is the variations in endogenous hormones, that is, hormones that are produced internally. And one of the easiest places to look for hormonal modulation is across the menstrual cycle. And we talked about the menstrual cycle in our previous lecture, but in general, we see that verbal, explicit, and implicit memory in women peaks as estrogen starts to peak right prior to ovulation, about day 14 of the menstrual cycle. Then as we get into the later part of the menstrual cycle, we see as estrogen declines but progesterone increases, we get sustained attention is highest during high progesterone days. And so as progesterone increases, we get changes in sustained attention. And so this provides a natural population for us to look at for these kinds of data analyses. Another area in which we can look is how menopause might affect cognition. What we see in menopause is often a rapid or even overnight loss of hormone levels, where we get reductions in executive functioning in late menopause and increased reaction time in simulated driving. So menopause can have pretty dramatic effects on cognition, and in fact, memory loss and difficulty concentrating is a very common complaint of women who are going through menopause. But let's take a look at this simulated driving time data. And what you can see is the X's on this graph represent postmenopausal women, the squares, women of reproductive age. And what you can see is the reaction time in seconds for women who are menopausal are dramatically different from those of reproductive age. And you can see these are people who are even relatively similar in age, and it's just simply whether they're menopausal or not that is a primary predictor of this data. Excuse me. I have a bit of a cold right now. So we also see in the perimenopausal period reductions in episodic memory. And so this is an area, this is a time in which hormone levels are starting to drop. In particular, estrogen levels are starting to drop. And we believe that estrogen seems to be a critical component of memory performance because it does seem to be protective of areas of the brain like the hippocampus. In males, we call this andropause, and this is not as well understood because the changes are much more gradual over time. So testosterone declines steadily with advancing age, starting in about the mid-30s, mid to late 30s is when testosterone levels start to decline. They tend to peak in the late 20s, early 30s, and then decline after that. This is one of the reasons why oftentimes males find it difficult to maintain their body fat levels, their muscle levels, because of the hormonal changes. In fact, oftentimes people see dramatic change in their metabolism right about age 30 or so, and it starts to become more difficult to maintain the same fitness level as we start to get older. But it's really important to do so because maintaining that fitness level allows you to maintain that testosterone level. So some longitudinal studies indicate testosterone concentrations can predict memory performance and cognitive functioning in elderly males, and that so as we look at people as they advance in age, then testosterone concentrations seem to be predictive. Part of the problem with that is that's tied up with things like fitness and et cetera. So staying fit is a really important part of this. We also know that if we look at patients who undergo androgen deprivation therapy for prostate cancer, we see reductions in visual, spatial, and executive functions in some of these patients. So these provide us with some natural populations to study these kinds of reductions in androgens. One area that's increasingly being looked at in terms of the relationship between hormones and cognition is looking at people who take oral contraceptives. So women who take contraceptives have a different hormonal milieu, and so they allow us to sort of look at how these drugs might be affecting cognition in these young women. So approximately 12 million women in the United States use oral contraceptives. Different formulations have distinct hormonal effects. The so-called second generation hormones tend to be androgenic, so they tend to increase androgen levels, so these can be trilevlin and orthonovin. The third generation tend to be less androgenic, so orthotricycline. Yasmin, which is not used very much anymore, is anti-androgenic, and it caused a number of health problems, so very few women are on it anymore. We'll talk about some research in this area in a moment. These all work by increasing progesterone feedback and reducing the release of gonadotropin-releasing hormone. And they also include replacement estrogen. So they increase the amount of progesterone feedback and then reduce the release of GnRH, and then include a replacement estrogen to replace the estrogen that isn't occurring from the development of a follicle. So what we tend to see in women on oral contraceptives is reduced menstrual cycle effects because we have relatively stable estrogen levels, and in fact some women go on oral contraceptives simply for that effect. Oral contraceptive use may boost verbal memory in some studies. One of a student that I worked with before, who's now a professor at Emory, Whitney Wharton, she did this terrific study when she was a graduate student and found that Yasmin users showed reductions in mental rotation compared to non-users of oral contraceptives. And that's, again, probably due to that reduction in the androgen levels in those patients. And then finally, second-generation users in those oral contraceptives tend to perform higher on mental rotation, again because they tend to promote androgens, and so as a result we see increases in mental rotation. I do want to stop for one moment and talk about the potential for a male contraception pill. This is an important development in sexual health, but also this is an area where we're going to have to start to think about how cognition might be affected in males taking an oral contraceptive pill. Women, of course, have borne the burden for very long, and it's time to try to have some equality in the contraceptive game. we'll have to start looking at how these drugs might affect cognition as well. So in the works are pills to inhibit spermatogenesis by decreasing gonadotropin-releasing hormone release and thereby decreasing testosterone production in the testes. The pill, though, has to include a replacement synthetic form of testosterone. One of the problems is that testosterone does not survive in the digestive tract, so this tends to involve alternative forms of administration, generally long-term injectables, or implantation of rods. This is another way in which contraception is done in women to provide sort of a slower, steady release of these drugs. The problem with the intramuscular injections, from what I have read, is that you tend to get this really significant increase in testosterone after the injection, and then as it wears off, you get reductions in testosterone, and so this can be problematic. The final area I want to talk about in terms of things like how drugs we might take affect cognition is looking at hormone replacement therapy. As we start to age, we can start thinking about replacing the hormones that we might have normally had. So for males, there's limited data on testosterone replacement therapy. There are lots of people taking testosterone replacement, but there isn't a lot of data. We do know, however, that for low testosterone males, testosterone supplementation does boost visual-spatial performance, consistent with everything we've been saying. There has been a lot of focus in menopausal and postmenopausal women on estrogen replacement therapy. And the evidence here is a little bit mixed. There is evidence that estrogen has been shown to repair hippocampal damage and to benefit and to protect the hippocampus. The current research indicates a number of important issues, that the type of estrogen matters, and that timing might be particularly important. And in fact, best results are if you start estrogen replacement therapy immediately following surgery or prior to your last menstruation. Now, one of the problems is there are health costs and benefits. There is evidence, of course, that estrogen replacement therapy may potentially be associated with long-term breast cancer risk, and so looking at breast cancer risk and talking these things over with your doctor are things to be considered. The last area we'll talk about in hormones and cognition is on hormonal supplements, and this is an area that, again, I've done some work in. DHEA is dehydroepiandrosterone, is available as an over-the-counter hormonal supplement. Naturally, this is the most abundant circulating hormone. Again, it's available as a supplement and as an indirect type of hormone replacement therapy. And the reason it's an indirect type of hormone replacement therapy is because it metabolizes into estrogens and androgens. As we spoke in our previous lecture, DHEA can be metabolized into androstenedione and into testosterone and then into estrogens. So here we have again this metabolic pathway. DHEA here is in the middle. It can be metabolized directly into testosterone or into androstenedione, then to testosterone, or then from either testosterone or androstenedione into estrone or estradiol and estriol. You used to be able to buy androstenedione over the counter, but was taken off the market. Not very clear why. If you look at this chart, you can see that taking androstenedione off and not DHEA didn't make much sense. But that's another question for another day. And we do know that DHEA does decline with age, again starting in the 20s. This again can be related to things like metabolism and potentially things like cognition. You notice men have higher levels of DHEA earlier in life. DHEA is a weak androgen, and so that's one of the reasons why it is higher in males than in females. We have seen in some of our work that DHEA supplementation can boost levels of both estrogen and testosterone in postmenopausal women. And so that can be problematic if you just want to increase your estrogen levels. You're also probably going to get increases in testosterone as well. So these are the data from some of our participants. The red lines are the women when they were taking DHEA. The blue lines are the same women when they were taking a placebo. We drew labs at 4 different times during the day. We also measured cognitive performance at these different times during the day. And you can see increases in estriol, estrone, total and free testosterone, and DHEA and DHEAS after a 4-week daily DHEA pill. We also found some associations with, I don't know why this won't stay on, things like recognition memory was positively associated with estrogen, but was negatively associated with androgens. Perceptual identification was negatively associated with, looks like, estrogen. My apologies for that. I don't know why that was happening. So we see boosts in estrogen and postmenopausal women, but we did not find really any benefits from DHEA administration in a variety of cognitive tasks. There are a couple of papers we have out on this, one by Bethany Stengel and then another by myself, where we see no benefit to these cognitive tasks. And then in our 2004 paper, we saw some associations with increases in hormone levels and performance, but again, we didn't see any increase in performance based on use of DHEA. Another question here is about anabolic steroids. This is an area a lot of people have questions about. It's a relatively unexplored field. There are limited studies of single doses of testosterone, and we've seen that it boosts mental rotation in women. This is a tough thing to investigate because most often the people who are taking anabolic steroids are doing so illegally, and so getting them involved in research is often difficult. Some potential solutions for this is to potentially look at things like HIV patients who are prescribed steroids. Some antiretrovirals have caused reductions in testosterone. And we could also look at male-to-female transgendered populations and female-to-male transgendered populations to look at how these hormones might affect cognition in these populations. Finally, I want to talk a little bit about some future issues in this area because there are so many things that can affect our hormone levels. In particular, the things that we need to think about in this area are potentials for treating cognitive aging. This is an area that I think a lot of people have some interest in. We also need to think about understanding the cost and benefits of nutritional interventions in physical fitness. Certainly, there are clear benefits for physical fitness and appropriate nutrition. We have to think about some of the costs of some nutrition. Things like soy can be mildly estrogenic, so people who take or eat or consume a lot of soy can oftentimes end up with high levels of estrogen and low levels of testosterone. And then there are also estrogenic and androgenic compounds that we have to think about. So things like BPA, which is bisphenol A, which is in a number of plastic products, which is what this book, The Slow Death by Rubber Duck, excuse me, is about. And then finally, pesticides and herbicides both have pretty strong hormonal effects. And so one of the things we have to think about is the effects of those compounds on our health as we're consuming products that have been sprayed with those and how they might affect our hormones and our cognition. All right, well, that's our discussion of hormones and cognition. We're going to finish this particular section out with a look at sexual behavior in the brain in our next lecture.